Hi, my name is Nguyen. Today I will present about the antimicrobial prophylaxis support system. Surgical site infection is a leading cause of patient injury, mortality, and excess healthcare costs. Each infection can increase the length of hospital stay, the likelihood of an intensive care unit stay, and the incidence of readmissions, as well as increase the risk of mortality. 2.6% of nearly 30 million operations performed each year are complicated by surgical infections. 40 to 60% of surgical infections are thought to be preventable with appropriate intervention. WHO recommendations on preventing SSI include both preoperative and postoperative measures. As you can see from the list, the use of preoperative surgical antibiotic prophylaxis has been emphasized as an important intervention to prevent SSI. Surgical antimicrobial prophylaxis, or SAP, is used to prevent surgical infection. 12 to 19% of inpatient antimicrobial prescriptions are for SAP. Appropriate administration of antibiotics prior to surgical incision has been associated with significantly lower infection rate. To achieve this goal, there are 5 criteria for appropriate use of SAP. An antimicrobial agent should be active against the pathogens most likely to contaminate the surgical site or insert the right antimicrobial selection. 2. Given in an appropriate dosage or the right dose. 3. At a time that ensures adequate serum and tissue concentrations during the period of potential contaminations, or the right time, usually within 60 minutes before the incision time or 120 minutes for some agents. 4. Safe, or match with patient's allergy characteristics and health status, comorbidities, and current treatments. And 5. Administer for the shortest effective periods to minimize adverse effects, the development of resistance, and cost, or the right duration. Usually, SAB should be discontinued within 24 hours after the surgery. However, data from Hospital National Antimicrobial Prescribing Survey found that 40% of surgical prophylaxis prescriptions were classified as inappropriate and 45% as non-compliant with national therapeutic guidelines. There are 34% were inappropriate with one or more reasons for inappropriateness documented. Reasons for inappropriate use of SAP include wrong timing, wrong dose, too broad spectrum, too narrow spectrum, wrong route, allergy mismatch, and microbiology mismatch. This is the clinical workflow with antimicrobial prophylaxis support, or APS system. The workflow starts at the inpatient ward or emergency room where the patient has been hospitalized and the surgeons prescribe the use of antibiotics for the surgery. The order from the surgeons will be sent to the hospital pharmacies where the pharmacist will dispense the medication from the hospital pharmacy storage. The medication will be sent to the pre-operation room where the nurse will prepare the patient and also the medication used in the surgery. The nurse will infuse the medication but not inject into the patient's body yet. And then when the patient is ready to go to the surgery in the operation theater, this is when anesthesiologist will administrate the medication into the patient's body to make sure that the antibiotic will be injected within the time frame of 60 minutes prior to the incision time. And during the procedure, if there is any blood loss does it too massive or prolonged procedure more than 3 or 4 hours, surgeons will decide to redose or add additional dose of antibiotic into the patient body. After finish the surgery, the patient will be moved to the recovery room or inpatient ward, and the SAB should be discontinued within 24 hours after the surgery. The use of antibiotics during the surgery will be recorded and reported to the stewardship owner, who is responsible for the antibiotic use in hospital. So the domain modeling for APS system will include 5 different parts: user, input data, output data, information system of the hospital, and event or location. The APS user include prescriber, which is surgeons, dispenser, for example, pharmacists from hospital pharmacies or inpatient pharmacies. Administrator include registered nurse from inpatient ward or operation room who is infuse the medication, and anesthesiologist who actually injects the medication into the patient body. And the last user is antimicrobial stewardship owners, who could be clinical governance staff or quality improvement staff. Input data for the APS include clinical rule, which is derived from clinical guidelines, local expert panel, and historical uses in the form of if-then rule and using data mining techniques. Surgical factors indicate the type of surgery. Patient factor includes 6 different attributes, include age, weight, allergy, medication, renal function, and patient identifier. Each of the attributes will be used to select the right type of antibiotics and calculate the right dose for the patient. And local resource, which indicate the available antimicrobial at the hospital, with information about active ingredient, manufacturer form, and quantity available. The APS system will exchange data with hospital information system, include EHR, pharmacy management system, OT or operation room or operation theater management system, and some others system. The APS output data include order set, which provide or recommend name of antimicrobial, the dose, the time, and administration route for the surgeons. Also, it alerts any conflict with allergy, history of the patient, or drug-drug interaction for the function used for the surgery during the prescribing step. The second group of output in notification include information about patient identifier, name of the antibiotics, dose, administration route for different users include pharmacist, nurse, and anesthesiologist. And the last group of output data from the APS is report feedback and antimicrobial record used for the stewardship owner, which includes information about data identifier, name of the antibiotics, total dose, including the initial dose and redose during the procedure. Timing include the initial time to start and the duration of antibiotic used on that patient, administration route, and administrators. An event and location of APS system will be served during the process of using surgical antimicrobial prophylaxis at the hospital. There are some limitations of the APS system. First is the alert fatigue if notifications are not selected carefully for health professionals. Second, Clinical rules or other sets needs to be agreed and supported by the local user, especially surgeons. Third, check-in time and duration, mainly based on manual input from user, include anesthesiologists and nurses. And last, this is quite challenging because multidisciplinary groups of users and multiple information systems interact in real time at separate locations, so the information system should have suitable capability to deliver output data at a right time. This is some of my reference. Thanks for listening.